Diseases of pulp and periradicular tissues. Pulp is a delicate connective tissue. It is just interspersed with blood vessels. Many tiny blood vessels are present. Lymphatics is present. Nerves are present. Myelinated and unmyelinated nerves are present. So that contributing to the nature of symptoms we notice in cases of pulpitis. The most common disease occurring as a sequelae of dental caries is the inflammation of pulp. That is nothing but pulpitis. Okay, pulpitis is the commonest cause of toothache. So there are different forms of pulpitis. Etiologic factors are basically the invasion of bacteria or bacterial products from the dental caries. A lot of microorganisms are responsible for causing the carious process. Their products may be just liberated into the pulp tissue, and they start the inflammatory process. And since the pulp, it is just enclosed within the calcified dentinal walls, it becomes a potential source for the inflammation to progress, and because of the presence of nerves and the blood supply, it just aggravates the inflammation, and we see the clinical features of pulpitis. So we'll study all the diseases of pulp and how the diseases of pulp, they affect the periradicular tissues. What are the manifestations of pulpal diseases in the underlying periosteum or the periradicular tissues? Okay. So we know the pulp tissue may be either infected because of some bacteria or the bacterial products. The dentinal caries may start the inflammation process in the pulp. So there are difference between the infected pulp and an inflamed pulp. Okay. So there are a lot of etiological factors responsible for causing caries. There will be mechanical trauma in the form of accidental exposure or iatrogenic during any dental procedure. If the accidentally the pulp is exposed, if the remaining dentin thickness is very less when you are carrying a restorative procedure, it may lead to iatrogenic exposure of pulp. And sometimes there may be fractures within the tooth, pathological fractures responsible for causing the inflammation of pulp. Or sometimes the excessive heat which is produced during cavity preparation, when you are repairing decayed tooth, what happens is because of the excessive vibrations and excessive heat produced by the handpiece, it may lead to thermal damage and inducing inflammation in the pulp. Okay, and this presence of dissimilar metals, suppose a gold metal is approximating a amalgamated restoration, that may lead to activation of galvanism and currents pass through, leading to damage to again pulp. Okay, because pulp is like vascularized, it is composing of nerves, blood vessels, lymphatics. The characteristic symptoms of pulpitis are seen, and they are very severe in clinical features and appearance also. And few of the acids whichever we are using in restorative materials, like the phosphoric acid, the acrylic monomer, or etchants, whatever we are using, they are like irritating to the pulp. And as I told you, the carious process begins with a lot of microorganisms. The microorganisms and their products, they just disseminate and release the inflammatory products into the pulp. And since the pulp is a closed chamber of surrounded by calcified dentinal walls, the inflammation just progresses at a very rapid phase. So the diseases of pulp, they are classified based on the nature, that is whether the pulpitis is of sudden onset or it is of a late onset, acute and chronic, based on the extent of involvement. If the whole of coronal pulp or the whole of pulp is involved, then it is known as total pulpitis. If only a part of the coronal pulp is involved, it is known as partial pulpitis. If whole of the coronal pulp is involved, excluding the root canal, subtotal pulpitis term is used based on the inflammation. If the inflammation is confined only to the crown, or if it is extending even into the root canals, it is divided as a partial pulpitis or generalized pulpitis. And based on the presence or absence of the pulpal infection, or based on the communication of the pulp to the oral cavity. Suppose the carious process is occurring, it has completely dissolved all of the enamel and dentin, and the pulp is directly exposed to the oral cavity. Based on that, It is divided as open pulpitis and a closed pulpitis. The open pulpitis, basically the symptoms, clinical symptoms are little bit more severe because the pulp chamber is not closed and it is just exposed to the oral cavity. Little bit lesser symptoms are seen. But the closed pulpitis, because it is a closed chamber, it is not exposed to oral cavity, aggravation of inflammation occurs leading to abscess formation. So we'll study the different pulpitis. Focal reversible pulpitis. As the name suggests, basically it is a reversible condition. It is actually induced by thermal changes. The inflammatory process has just begun in the pulp. It's also known as pulp hyperemia. It is a very, very mild transitory response, and whenever you just apply heat to the tooth or heat or any ice pack to the tooth, there is sudden aggravation of the symptoms leading to pain, and whenever the stimulus, the thermal stimulus is just removed, the symptoms subside on its own. And clinical appearance will show that teeth will have a very deep carious lesion, and some restorations may be present or recurrent caries may be occurring beneath the restoration that may lead to the progression of inflammation. Okay, and as I told you, thermal stimulus, whenever it is applied, only at that period the pain is seen. So the pain is relatively of shorter duration. As soon as the stimulus is removed, it just withdraws. And these are the clinical features of the focal reversible pulpitis. Okay, it is a reversible condition. It just resolves on its own. When you see the microscopic picture of a focal reversible pulpitis, you see that there is a dilatation of pulp vessels, so beginning inflammation is occurring, and there a little bit edema collection is seen in the connective tissue. Along with that, there is a strangulation of blood vessels, there is a slowing of blood flow, there is the polymorphonuclear leukocytes start appearing, and because of the inflammation occurring in the pulp, the inflammation is starting to occur, the dentinal tubules, the pulpal end of the dentinal tubules, this inflammation acts as a stimulant and it leads to form reparative or secondary dentin. Secondary dentin deposition is just as to counteract the inflammatory process occurring. Okay, so the focal reversible pulpitis, it is a reversible pain. Any attempt should be made to restore the tooth. That is because of a carious lesion it is occurring, right? So the caries is just removed, and because of secondary dentin deposition, the pulp won't be exposed and the remaining dentin thickness will gradually recover on its own, and thus it is a reversible condition. Now we'll see the acute pulpitis. Acute pulpitis, as the name indicates, it is an extensive acute inflammation of the dental pulp. Again, the clinical features are showing the presence of a large, deep carious restoration or occurrence of recurrent caries is present. Even though the tooth is restored, it is showing caries beneath the restoration. So, and the inflammation has progressed to the point that whenever you apply a thermal stimulus, the pain just aggravates very severely. The patient is not able to tolerate any thermal stimulus, cold or heat. And even when you remove the stimulus, the thermal stimulus is removed, the pain just persists and it is lingering in nature. Pain is of little bit longer duration. Even after removal of stimulus, it may persist for about 10 to 15 minutes. Okay. Initially, the pain is stimulated by thermal changes. Even after removal of stimulus, the pain persists. And whenever the pain is occurring, it may be of a deep, throbbing and lancinating type, just denoting the severity of the pain. So whenever the patient lies down, because of the pulpal pressure, it just tends to increase, and the patient will experience severe clinical symptoms, that is pain will be increased when the patient lies down. And when you carry out electric pulp testing, the tooth just responds to a lower level of electric current, indicating that the teeth are extremely sensitive. Okay, it responds to low level of the electric pulp testing. So there is great sensitivity in the tooth when compared to the adjacent tooth. And because the pain is lingering in nature, the patient may not be able to make out which tooth exactly it is. He just will point out to the jaw wherever he is feeling the pain. Okay, and the patient appears to be extremely uncomfortable and mildly ill. And when you see the microscopic picture of the early pulpitis or acute pulpitis, there is a dilatation of pulp vessels, early features of inflammation is present, inflammatory cells are present, polymorphonuclear leukocytes, they just begin to appear along the wall of vascular channels, lymphocytes show the features of diapedisis and they just tend to arrange themselves along the blood vessels. Okay, an accumulation of edema fluid in the connective tissue is seen. So beginning picture of microscopic inflammation is seen here. And as I told you, the early picture shows the dilatation, and as the inflammatory features progresses, the pulp tissue is completely infiltrated with lymphocytes, plasma cells, the blood vessels become more prominent, capillaries are more prominent, fibroblastic activity becomes more prominent, and even the collagen is beginning to be deposited here. So these are the microscopic features of acute pulpitis. So now we'll see the chronic pulpitis. Okay. The chronic pulpitis, it may arise on its own, or the acute pulpitis, when present for a long duration, it just progresses to become a chronic pulpitis. Okay, they are presenting little bit milder clinical symptoms when present to the acute pulpitis. Acute pulpitis is more painful when compared to the chronic pulpitis, and the patient complains of a mild dull aching pain which is just intermittent in nature. So it may be persist for few minutes, and the patient after that again the patient becomes normal. Even the pain is of relatively very dull in nature, and the thermal stimulus, whenever it is applied, the intensity of pain induced due to thermal stimulus is little bit reduced when compared to the acute pulpitis. And whenever electric pulp testing is carried out, the stimulation by electric pulp tester, it is also reduced, indicating the teeth have a greater pain threshold. Okay, they are not extremely sensitive here. The acute pulpitis is more painful, and the teeth are very sensitive. Okay, the teeth show greater sensitivity in acute pulpitis. And the dominant appearance of this chronic pulpitis is that pain may not be the common feature, just the teeth will have a very large carious lesion which is just open to the oral cavity. Deep dentinal caries will be present which has involved the pulp, indicating it is a chronic pulpitis which has become irreversible in nature. And there is other aggravating feature of the chronic pulpitis, that is the acute exacerbation of chronic pulpitis occurs in few instances, leading to the proliferation of tissue. Okay, that is nothing but this chronic hyperplastic pulpitis, also known as polyp. It is a unique pulpitis where what happens is the inflammation of pulp, it reacts by proliferation of tissues. So the connective tissue becomes proliferative in nature, and it shows the characteristic appearance of a polyp-like thing in the pulp. This pulp polyp is basically a granulation tissue. Okay, when we see the clinical features of this pulp polyp, because this is a proliferative reaction, it is more commonly seen in children and young adults who show greater tissue resistance and reactivity, who have greater blood vessel stimulation and leading to proliferation of the tissue. And clinically the teeth are little bit large, and they have a large carious lesion. Again, deep dentinal caries involving pulp is present. Pain is not the pinkish red globule of tissue protruding from pulp chamber is present. Pain may be present, but pain is not a constant feature here. Just a deep large caries cavity is present, along with that pinkish red tissue may be present in the pulp chamber. Pain is not a common feature. Okay, most commonly affected ones are the deciduous molars and first molar. And whenever the pinkish globule of enamel, whichever is present in the crown, it is just manipulated with a probe. It leads to bleeding of that particular surface because it is a proliferative reaction, right? But despite the manipulation of the pulp tissue and despite the bleeding, it is a little bit relatively painless one. And you have to differentiate this pulp polyp from the gingival tissue. There is sometimes what happens is deep proximal caries is present, and the gingival tissue just proliferates and occupies the proximal caries chamber. So to distinguish between the pulp polyp and the proliferation of the gingival tissue, you have to just make out the base of the stalk. For pulp polyp, since it is arising from the pulpal region, it's a proliferative reaction, there is no stalk attached. There is no attachment to the gingiva. But when there is proliferation of gingival tissue, if you just manipulate with the probe and see, you see that there is connection of that tissue with the gingiva, indicating it is a proliferative tissue of the gingiva. So that's the distinguishing feature here. Now when you see the microscopic picture, as I told you, this is a proliferative reaction of pulpitis, and it's basically a hyperplastic tissue. Granulation tissue is present. The granulation tissue basically shows various number of capillaries are present, inflammatory cell infiltration, chiefly lymphocytes and plasma cells are more prominent. Along with the fibroblastic activity, endothelial cell proliferation is more prominent in cases of chronic hyperplastic pulpitis. Treatment for chronic hyperplastic pulpitis again includes nothing but endodontic treatment or extraction of the offending tooth if it is a deciduous one and is not treatable. Most commonly the deciduous molars and the first permanent molars are affected. In case of permanent teeth, endodontic therapy has to be carried out. Okay. Now once the diseases have involved the pulp, okay, now what happens is next this tends to spread in the periapical region. They involve the periapical region, they involve the periodontal ligament which is surrounded near the root apex, which is surrounding the root. If the inflammation is involving the periodontal ligament, then it presents the features of periodontitis. So we'll see the acute apical periodontitis, the chronic apical periodontitis. Acute apical periodontitis is nothing but the inflammation of periodontal ligament around the root apex, and the etiology is nothing but a pulpitis, either a chronic one or acute pulpitis. It just progresses to involve the periodontal ligament, and obvious clinical history of previous pulpitis involving a pulp will be obviously present in features of acute apical periodontitis. And the thermal changes, if you apply a stimulus like a heat or a cold, it does not induce any pain in cases of thermal pulpitis. Instead, if you percuss the tooth, either a horizontal or a lateral percussion, it produces relatively more severe pain, because whenever the inflammation has spread from the pulp, from the root canals, and it is involving the periodontal ligament, what happens is there is relative widening of the periodontal ligament space, and the tooth just tends to be extruded out of the socket because of the accumulation of edema fluid in the root apex. In the periodontal ligament, there is accumulation of edema fluid. It is leading to elevation of the tooth in the root socket, and tooth is very, very tender to touch. The external pressure of the tooth results in severe pain. What happens is there is the edema fluid is present, and whenever the tooth is just touched or during mastication procedure, what happens is this the root apex is just forced against the edema fluid, which just activates pressure on the nerve endings, leading to extreme pain here in this case. The tooth is elevated in socket clinically. It may not be that mobile also. Okay, but elevation is obvious. And when you see a radiographic picture of acute apical periodontitis, there is widening of the periodontal ligament space present. Okay, initial features show widening of periodontal ligament. When you see the microscopic picture, again signs of inflammation will be present, which are involving the periodontal ligament. Infiltration of polymorphonuclear leukocytes along the periodontal ligament space is seen. Initially, what happens is the changes of inflammation, they are just constricted to the root apex. So once the inflammation progresses, and if the pulpitis has progressed to the extent that it is not being removed and constantly the periodontal ligament is being irritated, the infection, it just tends to progress and involve the surrounding bone also. Alveolar bone is involved, leading to resorption of bone in acute stages. Okay, sometimes the inflammation or the edema formation may be such excess in nature that it leads to abscess formation in the periapical region. So treatment for acute apical periodontitis includes endodontic therapy for that particular tooth, and or surgical extraction if it is not treatable. Chronic apical periodontitis, it is also known as periapical granuloma. Basically, chronic apical periodontitis is that the acute apical periodontitis, if it is not treated for a longer period of time, it may just progress to chronic apical periodontitis, or sometimes what happens is just the chronic pulpitis, it may directly show the appearance of a chronic apical periodontitis. It may directly show the chronic features. When we see the radiographic picture, we'll see that a radiolucent mass is present involving the root apex. That is nothing but a periapical granuloma actually. Basically, this granuloma is nothing but a localized mass of granulation tissue which is formed in response to the infection, that is the pulpal inflammation which is occurring. The etiologic factor is the pulpal inflammation. If it is just progressing to the point that granulation tissue is formed in the root apex, and the involved tooth, usually it becomes non-vital. So there are no characteristic symptoms of pain here. Okay, but only thing is when you percuss the tooth, instead of pain, normally you when you percuss the tooth, you see a sharp sound because of the alveolar bone present. But here in case of periapical granuloma. It is nothing but a soft tissue, granulation tissue involving the root apex. So when you percuss the tooth, you see a dull sound is produced. Okay, only when the individual is biting on a hard food, he seems to feel pain. Okay, and as in the characteristic features of acute apical periodontitis, the tooth may be slightly elongated in its socket, and because of the edema fluid collection, and it is entirely asymptomatic, and there is no the signs and symptoms of inflammation which are involving the periodontitis, they do not involve the bone here. Okay. No perforation of the mucosa or underlying sinus formation is seen. The inflammation changes are confined to the periodontal ligament only. So when you see the radiographic picture of chronic apical periodontitis, initially you see that the periodontal ligament becomes thickened. Okay, there is thickening of periodontal ligament. Along with that, as I told you, periapical granuloma appears as a radiolucent area attached to the root apex. Thin radiopaque lesion surrounds the bone, and as the infection progresses, there is resorption of bone. So that's about chronic apical periodontitis. Again, treatment for chronic apical periodontitis includes endodontic therapy along with curettage sometimes may be required if the periapical granuloma has formed, right? So curettage, apical curettage, episectomy may be carried out sometimes. Endodontic therapy, if not treated, surgical extraction can be carried out. And when you see the microscopic picture of the chronic apical periodontitis, again the inflammatory picture as seen in the acute apical periodontitis may be present. There is edema of periodontal ligament, there is hyperemia of periodontal ligament along with inflammatory cell infiltration. Infiltration characteristically with lymphocytes and plasma cells may be seen, and fibroblastic activity is evident, endothelial cells proliferate, and because of the granuloma, it is basically a highly vascular tissue, right? So we know that periapical granuloma is of extensive vascular in nature. So there are formation of tiny vascular channels. Along with that, numerous delicate connective tissue fibrils appear to be interspersed in the connective tissue. And the treatment is nothing but endodontic therapy, surgical extraction. In some cases, curettage may have to be carried out to remove the granulation tissue completely, or sometimes episectomy has to be carried out. Now, what happens is once the granuloma formation is there, okay, pulpitis has occurred, it has progressed to the level of involving the periodontal ligament, periodontitis has occurred, then what happens is granuloma formation has occurred. This granulation tissue, essentially what happens is it tends to increase in cells because of epithelial cell proliferation. Sometimes the epithelial rests of molasses, whatever are done, the rest cells, they beginning to show epithelial proliferation. That epithelial proliferation leads to increase in size of the granuloma cells in the periapical granuloma. So the innermost cells present within the periapical granuloma, they are just deprived of nutrition because the blood vessels from the outer cells are only supplying nutrition to all of the cells in periodontal ligament. The innermost cells are deprived of nutrition, they just become necrotic, and ultimately they degenerate and form a cystic cavity within. That leads to formation of a apical periodontal cyst. Okay, we have studied in detail about the apical periodontal cyst in the cysts of our odontogenic cysts of oral cavity. Okay, it's also known by other names like a radicular cyst or a periapical cyst or a root end cyst. As I told you, etiology is nothing but the epithelial remnants of the periodontal ligament, that is the cell rests of molasses. So periapical granuloma formation occurs initially, then it leads to periapical cyst formation. Clinical features of periapical cyst is that it can be seen in any age, more commonly in the 4th decade of life. It is slightly more common in males and than in females. Etiology is nothing but in pulpal inflammation progression, and the patient may be completely asymptomatic, or sometimes patient may have a dull aching pain. As with periapical granuloma, features of severe acute pain may be lacking. Okay, suppuration of the cyst may sometimes lead to abscess formation within the periapical granuloma. This cyst is of such a small in size, and it rarely causes a bone expansion. Sometimes resorption of bone, alveolar bone may be seen. When you see a radiographic picture of a apical periodontal cyst, periapical round or ovoid radiolucency of variable size may be present with which is surrounded by a radiopaque ring, which is relatively showing a thin sclerotic bone surrounding it. Okay. Basically this cyst is associated with the root apices of the infected teeth only. It usually does not exceed more than 1 centimeter in diameter. When you see the microscopic pictures, since the apical periodontal cyst is a true cyst, it is lined by epithelium. There is nothing but the stratified squamous epithelium, and the connective tissue wall of the cyst shows presence of the mature collagenous connective tissue along with abundance of fibroblasts, lymphocytes, and the characteristic plasma cell cartwheel nuclei may be seen, and the rust and body are nothing but linear hyaline bodies present within the periapical granuloma. The lumen, basically the cyst has a lumen, right, which is filled with fluid, and which shows the content of the fluid is one of a low molecular protein. That is, a low concentration of fluid is present, and it stains eosinophilic in Hetton staining. So these are the microscopic pictures. One of inflammation lined by epithelium, the cyst lined by epithelium, the connective tissue proliferation along with the characteristic linear hyaline bodies is seen. Treatment is nothing but extraction of the involved teeth, or sometimes curatives have to be carried out. Sometimes the excessive proliferation of the periapical granuloma tissue or the granulation tissue, it leads to abscess formation, suppuration within the granuloma leading to abscess formation. It's also known by other names as the dentoalveolar abscess or the alveolar abscess. It is basically a acute suppurative reaction which is occurring in the periapical region. It may be present in the labial, alveolar or lingual region. Anywhere whenever the infected tooth is present and abscess is formed in the tooth, it tends to discharge onto the mucosal surface through a sinus tract, fistulous tract formation. Okay, the acute exacerbation of abscess sometimes occurs. It is known as a phoenix abscess, and the clinical features of abscess may be presence of intraoral swelling with pus discharge, and the tooth will be extremely painful in nature. It will be extremely tender to touch, and the tooth appears to slightly elevated from its sockets because of the underlying edema fluid collection there. And sometimes what happens is the abscess or the pus, whatever is deposited, it may discharge onto the skin surface. It may also involve the bone and tends to spread through the marrow spaces, leading to formation of osteitis or osteomyelitis. Okay, clinically you can see a swelling. When you see the microscopic picture of this acute periodontal abscess or a periapical abscess, you see that the periodontal ligament space is thickened, and there is appearance of a radiolucency in the root apex involving the particular root. And the chronic abscess basically presents the features of just a radiolucency or abscess formation at the apex, which is relatively diffuse in nature. It is not surrounded by any radiopaque rim as seen in apical periodontal cyst. Okay, cyst is of uniform size, and it is well circumscribed, and it is surrounded by a radiopaque rim or a thin rim of sclerotic bone. Whereas abscess is little bit diffuse in nature. It is not circumscribed, and it is not surrounded by any radiopaque rim. Okay, when you see the microscopic picture of a periapical abscess, you see the characteristic again inflammatory features. There is the polymorphonuclear leukocytes predominate, and they are just surrounded by leukocytes also. Cellular debris, necrotic materials, and bacterial colonies tend to be accumulated there. Treatment for the periapical abscess is nothing but drainage of the abscess. It is endodontic therapy. Once instituted, it leads to rapid resolution. The pus may just has to find a way to come out. So when you carry endodontic therapy, the pus just tends to come out through the root canals, and once it leads to resolution symptoms, because the abscess formation, it leads to a characteristic loss of bone within that particular region. It may take few months for the bone to again form in that particular region. If the abscess is not treatable and it is not healing, then you have to extract the tooth. So that's about the diseases involving the periapical tissue. So once the caries process is occurring, it's involving the pulp, it's involving the periodontal ligament, and the abscess formation has occurred. Okay, the tooth has progressed to such an extent that, okay, the disease process in the tooth has progressed to such an extent that after the abscess formation, the abscess is diffuse in nature, right? So it tends to spread and involve the underlying bone also. So the inflammation of bone and its marrow contents is known as the osteomyelitis. Osteomyelitis, it's relatively more common in the mandible because of the diffuse nature and the diffuse spread of the process occurring there. Okay. Periapical abscess formation, pulpitis progresses to apical periodontitis. Apical periodontitis may again lead to either an abscess formation or a granuloma formation. The granuloma formation may either lead to cyst formation, or it may form the abscess again, which tends to spread and involve the bone. Osteomyelitis feature. Osteomyelitis again, it may be acute or chronic, or it may be focal, seen at only one place, or it may be diffuse, involving the whole of bone. Or the osteomyelitis may eventually spread and involve the superficial skin or oral mucosa, leading to cellulitis, and ultimately sometimes the pus formation, it just tends to spread into the facial spaces and causing the characteristic abscesses of that particular region, or facial infections as we call may occur. This study about osteomyelitis. Osteomyelitis is basically an inflammation of bone and its marrow contents. Okay, what are the factors associated with the development of osteomyelitis? Invariably, the pulpal infection or a periodontal infection was present in an immunocompromised patient. Okay, or the cavities were in fracture line. The teeth were fractured already. There is loss of blood supply. There is disruption of blood supply because of the fractured occurring in that particular jaw. Furthermore, the cavities are present with the infection. These both features, they tend to aggravate the condition, leading to osteomyelitis. Sometimes the fracture is occurring in the bone. Fracture is nothing but the break in continuity of the bone, leading to disruption of even the blood supply, and that area tends to be lose its blood supply, leading to formation of progression of infection, leading to osteomyelitis. Okay, so the trauma is the most common reason for predisposing factor for osteomyelitis to develop. I will study the acute suppurative osteomyelitis, the chronic suppurative osteomyelitis. In the chronic forms, we'll see the focal sclerosing osteomyelitis and the diffuse sclerosing osteomyelitis, and there is a special osteomyelitis known as the Garis non-sclerosing osteomyelitis. Okay. Acute suppurative osteomyelitis. The etiology for any osteomyelitis occurring is a sequelae of a periodontal infection, periapical infection. So the periapical infection, the inflammation of pulp, the chronic pulpitis, the apical periodontitis, they just progressed to abscess formation and then ultimately leading to osteomyelitis. What happens is actually there is a diffuse spread of the infection which is occurring through the medullary space. The inflammation is just involving the medullary space and progressing. In case of predisposing factors present like trauma leading to disruption of blood supply. Furthermore, this infection tends to aggravate in such instances, leading to necrosis of some viable bone. Okay, the normal viable bone, because of disruption of blood supply to that particular segment, it just becomes necrotic and separates out. That's how the osteomyelitis actually progresses. The features of acute osteomyelitis may be involving both the maxilla and mandible, but mandibular region is one which shows diffuse spread of the process. Okay, and there was acute suppurative osteomyelitis which is occurring particularly in infants, known as neonatal maxillitis. The neonatal osteomyelitis is basically involves the maxilla, and features of acute pain may be present. Okay, this neonatal maxillitis occurring in children is basically of hematogenous origin. That is, it tends to spread through the blood and it involves the maxilla. Characteristic features of acute suppurative pulpitis are wherever there are acute, the term acute is used, it denotes that the osteomyelitis is of sudden onset, so severe pain is seen. Along with that, the involved muscles or the involved submucosa, it shows characteristic trismus, and sometimes because of involvement of the nerves, there will be paresthesia of that particular region, and clinical symptoms of systemic symptoms of elevated body temperature, mild illness, fever may be present. Along with that, the inflammation is progressing and involving even the regional lymph nodes, giving rise to the features of regional lymphadenopathy. And when you see the oral cavity of region affected, the acute suppurative osteomyelitis, clinically it just presents as a swelling in the oral cavity. Okay, and when you see the oral cavity internally, you see that all the involved teeth, they just become very, very loose, and they will be very, very painful, and sometimes even pus seems to exude from the gingival margins. And since the inflammation is involving the bone, there is severe pain in that particular region, and there is inflammation of even the periosteum of the bone. Periosteum is the outermost layer of the bone, so that periosteum is inflamed. And when you see the radiographic picture of acute suppurative osteomyelitis, you see that the individual trabeculae, they lose their viability. They just tend to become fussy and indistinct. The trabeculae just showing that the osteoclast may be activated, leading to resorption beginning to start in cases of acute suppurative osteomyelitis. Hence, the trabeculae they just become very indistinct, and radiolucent areas begin to appear, giving the characteristic mottled appearance to the bone. Okay, and when you see the microscopic picture of basically osteomyelitis is involving the inflammation of the marrow spaces, right? The medullary spaces, they are just filled with excessive inflammatory infiltrates or inflammatory exudates, that is the lymphocytes, polymorphonuclear leukocytes, plasma cells may predominate, and sometimes the osteoblasts, whichever are boarding the cortex of bone, they are destroyed. And treatment for this acute suppurative osteomyelitis is nothing but drainage of the abscess, debridement of that particular area, and as I told you, this inflammation, it leads to necrosis of the viable bone, leading to formation of a sequestrum. Sequestrum is nothing but non-vital bone which has been just separated out from the viable bone. This sequestrum may be formed in the jawbone, and sometimes it is very small, and it just tends to exfoliate through the soft tissue. And sometimes if the sequestrum or the necrosed bone, it is relatively larger and it is just present and visible on the radiograph, you have to just excise it surgically. If sometimes during procedures, what happens is the necrosed bone or the sequestrum, it begins to show that is, it is being surrounded by a viable bone, that is nothing but the involucrum. Okay. So that's about the features of acute suppurative osteomyelitis. If you see the chronic suppurative osteomyelitis, as the term indicates, the disease is of chronic nature. So the acute suppurative osteomyelitis may have been present for a longer duration of time, that leads to characteristic symptoms of seen in acute suppurative. Whereas chronic suppurative osteomyelitis, it is different from acute in its etiology. That acute suppurative osteomyelitis is arising because of a periapical infection, whereas chronic suppurative osteomyelitis is arising because of a periodontal infection occurring. So what happens? Initially, it develops in cases of acute osteomyelitis. Okay, acute osteomyelitis is one treated, they may show this chronic suppurative osteomyelitis or any dental infection occurring. Here the chronic features, as always seen in cases of chronic pulpitis also, the characteristic symptoms of pain are relatively less severe or moderate or absent. And still the generalized systemic symptoms of fever is present, the temperature of the body is elevated, leukocytosis is great, the teeth may not be so loose as seen with the acute forms of the disease, and sometimes acute exacerbation of the chronic suppurative osteomyelitis may occur, that lead to suppuration and abscess formation, and this suppuration or abscess, they just tends to perforate the bone, the overlying mucosa of the skin, mucosa or skin, and leads to a fistulous tract formation, leading to discharge of pus onto the external surface. Okay, so that's about the chronic suppurative osteomyelitis. As you know, the chronic features, they show depending on the spread of the disease, the chronic osteomyelitis may be a focal one, that is, it is just deposited or seen in particular area, or the chronic osteomyelitis just tends to involve whole of the bone. So it's known as chronic focal sclerosing osteomyelitis, also known as condensing osteomyelitis. Any infection to the bone underlying, if it is just aggravated, it leads to this condensing osteitis formation. As the name indicates, condensing osteitis, that is nothing but deposition of bone is occurring, some amount of bone is occurring here. Osteitis, inflammation of bone, condensing type. Okay. Mild bacterial infection occurring in the oral cavity or presence of a carious tooth, any periapical infection may be the causative, that is leading to the reaction by the bone. Okay, how the bone reacts to a mild bacterial infection, we'll see now. Basically, this chronic focal sclerosing osteomyelitis is seen in cases of children and younger adults. Clinically, there are no signs and symptoms of the disease. It is a relatively mild disease, no clinical symptoms and features. When you see the microscopic picture only, you see that a radiopaque mass will be surrounding the roots of the tooth. Okay, radiopaque mass will be surrounding the roots of the tooth, and the associated tooth, whatever is present, the pulpal infection will be present in that tooth, the carious process will be present. And this radiopaque mass, it is made of essentially of sclerotic bone, and it is very smooth, and it is distinct from the surrounding normal trabeculae or the alveolar mucosa. Okay, when you see the microscopic picture of the chronic focal sclerosing osteomyelitis, you see that The radiopaque mass is present. It is essentially consisting of the osteoblast deposition, and the adjacent bony trabeculae, they show the appearance of osteolytic activity. Osteocytic lacunae appear, they appear to be relatively empty, and the trabeculae, they exhibit many reversal and resting lines. That is, osteocyte deposition is present, osteoblast activation is present. Condensing osteitis is the characteristic feature of showing the this reversal and resting lines, known as the pagetoid appearance of bone. Okay, is the cotton wool appearance, also known as the term is given for that. There is few areas show deposition, few areas show resorption. And lymphocytes are invariably present in the microscopic picture, showing the inflammatory process occurring. Treatment for this condensing osteitis is nothing but endodontic treatment of the tooth, or sometimes extraction of the tooth have to be carried out. The chronic diffuse sclerosing osteomyelitis, it is a special form of osteomyelitis in that it is the proliferative reaction of bone to a low-grade infection occurring. So any reaction, any low-grade infection of oral cavity is periodontal infection, that is involving the periodontal ligament and the teeth. Okay, so the low-grade periodontal infection, it just spreads and involves the surrounding bone, leading to spread of inflammation, ultimately osteitis occurring. The clinical features here are relatively lesser in severity. There are actually no characteristic clinical features seen. Basically, this chronic diffuse sclerosing osteomyelitis, it may occur at any age. More commonly, because of the periodontal problems, it is seen in older age individuals, we can say. And edentulous regions or edentulous jaws more commonly show this chronic diffuse sclerosing osteomyelitis. And sometimes there is acute exacerbation of the disease, leading to characteristic wake pain, unpleasant taste, and discharge of pus may be seen in the oral cavity with a fistulous tract formation because of the underlying inflammation occurring there. When you see the microscopic picture of, when you see the radiographic picture of this chronic diffuse sclerosing osteomyelitis, characteristic cotton wool appearance may be seen. That is, a diffuse patchy sclerosis of bone is being seen radiographically, and whatever radiopaque deposition is seen, it is bilateral, that is involving both the roots of teeth. If that particular teeth is affected or that particular jaw is affected, both the sides of the jaw show this characteristic cotton wool appearance. When you see the microscopic picture, there is a dense irregular trabeculae of bone. These irregular trabeculae of bone are bounded by a layer of osteoblast, showing that deposition of osteoid is occurring at radiographic level. And then some focal areas of osteoclastic activity may be seen along with the osteoblastic activity, thus it is giving a mosaic pattern appearance. And the soft tissue, when you see, essentially it's showing the appearance of fibroblasts. And polymorphonuclear leukocytes predominate. If the inflammatory component is very, very severe, sometimes the bone just tends to deviate from the normal bone. There is sclerotic type of bone. It's just remaining in the viable bone. That is nothing but the inflammatory or burned out component of the bone. When you see the treatment, it is basically to remove the teeth surgically, because it is very extensive lesion, and it is basically just a reaction of the bone to periodontal infection. Periodontal infection is a low grade infection, but the bone seems to show excessive reaction to the normal stimulus or a low level stimulus. Okay, antibiotic therapy has to be given to just make the patient, make sure that the infection is resolved, and extraction of the tooth may have to be carried out. And this is about the chronic diffuse sclerosing osteomyelitis. Okay, focal forms of osteomyelitis, chronic focal sclerosing osteomyelitis, it is just confined to the root of the tooth, whereas the chronic diffuse sclerosing osteomyelitis, as the name indicates, diffuse, it is of rapid, widespread nature, and this was whole of the jawbone. The characteristic cotton wool appearance is involving whole of the mandible, if it is seen in case of mandible. Sclerotic cemental mass, it is very similar to the chronic diffuse sclerosing osteomyelitis. Instead, whatever osteoid is being deposited, when it is studied, it is seen that the osteoid deposition is nothing but cementum. Okay, so histologic appearance of cementum is seen. So the term sclerotic cemental masses is given. It is also a form of just a chronic diffuse sclerosing osteomyelitis only. And clinically, you see that multiple symmetric lesions may be present, which may be slightly showing a bony hard swelling on the outer surface of cortex, as in chronic diffuse sclerosing osteomyelitis or chronic osteomyelitis forms. Pain may be present here, and the drainage will be present, that is pus discharge will be present, along with expansion or swelling of the jaw. When you see the microscopic tissue, the tissue is one of cementum. Okay, And cementum, basically it appears as large solid masses within lobulated margin, with showing a globular accretion pattern when seen histologically or microscopically. Chronic osteomyelitis with proliferative periostitis. As the name itself indicates, the features of chronic osteomyelitis are seen along with the characteristic inflammation which is involving the periosteum or the outer layer of the bone, outer layer of cortex, that is the periosteum. The inflammation of periosteal thickening is seen along with features of chronic osteomyelitis. It's also known as Gary's chronic non-suppurative sclerosing osteomyelitis. Originally, when Gary, the author, he proposed this form of osteomyelitis, he did not show any symptoms of periostitis. It was later on put forward that periostitis also occurs in case of this Gary's chronic non-suppurative osteomyelitis. So focal gross thickening of periosteum, that is the characteristic feature of here. Essentially, reactive bone formation, peripheral reactive bone formation is present. The features of chronic osteomyelitis are common as seen in case of other chronic forms of osteomyelitis. There is some form of irritation occurring to the bone, and this Gary's osteomyelitis is characteristically seen in children and young adults, because children and young adults are the ones who have extensive tissue reactions, extensive hypersensitive reaction to any irritation. They have the characteristic to show the extensive reaction to any mild irritation also, because of the proliferative reaction and high degree of tissue resistance present in children. And more common, the site involved is the bicuspid and the molar region. Maxilla is not affected that commonly. It's more commonly involved in the mandible. Characteristic features of pain in the jaw is present. Along with that, swelling and expansion of the cortex is present. The swelling is characteristically very hard in nature. When you see the radiographic appearance, you see that some infection like a mild carious process or a carious process involving the tooth and pulp is present opposite this thickening of the periosteum or the gross thickening of periosteum. The thickening of periosteum is such a nature that it may give an indication of a duplication of layer of cortex. So one cortex layer is present because of the extensive periostitis occurring. There is other thickening, excessive thickening of the cortex. It's giving the appearance duplication of the cortex layer. Okay. So when you see the microscopic picture of this characteristic, the subperiosteal mass, it's essentially composed of osteoid deposition because of the reactive bone formation. Osteoblasts are activated, osteoid deposition is there. So many osteoblasts may be bordering the bony trabeculae. The connective tissue is essentially fibrous in nature. So the treatment for this form of osteomyelitis is again endodontic treatment or surgical excision of the tooth or extraction of the tooth have to be carried out if endodontic therapy is not possible. And no other treatment may be required other than the endodontic therapy for all forms of chronic apical infections or pulpal infections or periodontal infections. If endodontic therapy is not possible, only then extraction of the tooth is suggested. So we have studied the diseases of pulp and the periradicular tissues.